Syndrome is a predominantly male genetic disorder with a prevalence of 0.1 to 1% of the population. It results in an increased risk of ventricular tachyarrhythmias and sudden cardiac death. Unfortunately, these people's hearts appear structurally normal because the change is actually typically due to a mutation in the sodium channels, which causes a change or an abnormality in the electrical conduction of the heart. It is inherited in an autosomal dominant pattern. However, variable expressivity can make it difficult to diagnose with family history alone. Furthermore, the mutation can be new in the patient that is symptomatic, so there may be no family history at all. So diagnosis is typically made by identifying the characteristic Brugada pattern on an EKG, which is a pseudo-right bundle branch block in leads V1 and V2. But this change or this pattern can be transient in nature on the EKG, so it can be very difficult and can lead to a delay in diagnosis because the symptoms can come and go. Unfortunately, this means that it usually is unmasked by a trigger, such as cocaine use or a fever, and these patients then can be found highly symptomatic and have no pre-existing condition. And we actually present one such case today. Our case was a 19-year-old male with no known medical history who presented to the emergency department after being found down by his parents. He was unresponsive to multiple doses of Ativan and Narcan and was tachycardic to the 150s with respiratory insufficiency. He was intubated in the ED, and an initial EKG, shown here in figure A, showed sinus tachycardia but no ST changes. A urine drug screen was performed and was positive for THC, and labs showed elevated procalcitonin, D-dimer, potassium, and LDH. High suspicion for a pulmonary embolism was present, so we performed a CT angiogram, but there was no evidence of a pulmonary embolism. However, multilobar pneumonia was seen, so follow-up testing was done and confirmed that he was COVID-19 positive. Shortly after that, the patient's heart rate rapidly decreased, and a second EKG was performed, seen here in figure B. The EKG did show evidence of a type 1 Brugada pattern with coved ST elevations and negative T waves in V1 through V3. At that point, the patient then converted into pulseless VFib, and CPR was performed, and ROSC was achieved. A further EKG done after ROSC was achieved, here in figure C, did show resolution of the Brugada type 1 pattern. However, unfortunately, the patient did ultimately expire from an anoxic brain injury. Patients with Brugada syndrome typically first present after a syncopal episode or sudden cardiac arrest due to an apparent lack of cardiac abnormalities on the routine testing that we perform. And although genetic mutations have been identified with Brugada syndrome, cardiac arrhythmias typically do not appear until triggered. So a high degree of suspicion for Brugada syndrome is necessary anytime we see a young male patient who presents with syncope or cardiac arrest or some form of an abnormal EKG, specifically in the setting of either substance abuse or a febrile illness. So specifically, currently in the context of COVID-19, which is associated with high fevers, physicians should be particularly aware of underlying causes that can put young patients at risk of sudden cardiac death when they are infected with COVID-19. Additionally, we should pursue aggressive antipyretic therapy, especially in these young patients with COVID-19, in order to decrease the chances of triggering or unmasking Brugada syndrome that could progress to sudden cardiac death.